Thank you to all of you. Thank you for having invited me to talk about Mycoplasma proctitis. A few introductory words regarding STIs, or sexually transmitted infections. Their incidence is constantly on the rise since the introduction of pre-exposure treatment. Now, regarding urogenital mycoplasma, these are the smallest prokaryote. They have no walls. They are not sensitive to beta-lactamines. You can have the uroplasma, mycoplasma hominesis. These are commensal ones. It's quite common to find them in the urogenital flora. And mycoplasma genitalium is an STI with direct contact contamination. Frequency is very high for asymptomatic patient. No, MG, you see the prevalence is the urethral prevalence is approximately 1% in the general population, up to 16% with people at risk. The risk factors are several sexual partners, non-protected sexual intercourse. No. MG, Mycoplasma genitalium, is a demonstrated pathogen. It is considered to be 35% of urethritis, non-chlamydia, and it can be also the causes of cervix infections and endometritis. No, the prevalence is extremely high for the anorectal, with more than 10% for men having sex with men with usual risk factors, non-protected sexual intercourse, people with HIV, non-PrEP. It can be combined with other STIs because they usually go in combinations. No, would it be a simple infection of the rectum? It might be other microorganisms involved. Now we see that there are many signs pointing at MG. As I said, very high prevalence rate, even higher in case of proctitis. For men having sex with men, the prevalence is twice as high when there is no as opposed to non-proctitis patients. In case with MG infection, the bacterial load is even greater, more bacteria when you have proctitis, as opposed to non-proctitis. As I said, it's always combined with other infections. This study was carried out in our center, 365 patients with a suspicious of infectious anoproctitis. You see the MG infection rate was very high, 15%. And it was isolated in almost 2/3 of the cases. And as I said, it's often a non-symptomatic infection, but that's the case of most STIs. These are a recent study from 2025. It's also true for gonococci, chlamydia, while nobody has a doubt about their pathogenic nature. So, indeed, it is a reality. These are the recommendations from the European Academy of Dermatology, Venerology, who have included MG in their causes of distal proctitis. Now, let's talk about the diagnosis. It means pain, oozing when it comes after MG infection. It's not so obvious as opposed to chlamydia or gonococci infections. Diagnosis is simple: molecular biology with a direct detection of the bacteria with a swab PCR. There is no growth. It's a direct detection. And it's molecular biology also for systematic identification of macrolide resistance with 5 mutations which have been identified with PCR. The sample is taken in case of an infectious anoproctitis after exclusion of other causes like chlamydia and NG that are more frequent, and we know that they are always involved in proctitis. No, these are the European guidelines. There is another slide after that. These are the latest ones. First line, no resistance to macrolide. You can use azithromycin and moxifloxacin in case there is a resistance to macrolides, which is very high in men having sex with men. More than 80% resistance. You have an increasing rate of quinolone resistance cases below 20%. No. If we consider the English-speaking countries, you have doxycycline twice 100 milligram for 7 days, which is not going to eradicate the bacteria. It's only 30% for the eradication rate, but it helps to reduce the bacterial load and reduce the selection of macrolide-resistant strains. After that, azithromycin, if there is resistant, azithromycin for 3 to 4 days, depending on the countries. And in case of macrolide resistant, moxifloxacin. So that's what is usually done, a kind of sequential treatment. It's not an easy disease to treat, and that is why research considers that you have to consider this in case there is no chlamydia or gonococcus infection. No, GM infection is very frequent for men having sex with men and people living with HIV. It can be the simple causes of anoproctitis. It might you have to go for elimination diagnosis, excluding chlamydia and gonococcus. It's PCR diagnosis with anorectal swab. You have to consider the macrolide resistance because those rates are going on the rise. Thank you for your attention. If you want to know more about it, colloproctotally of the ESSP will be held in Paris. And regarding these STIs, I will invite you to read Vogel, a former resident in our ward who has produced an excellent work on this. Thank you for your attention. Any questions? Thank you. It was very interesting. Some patients have anal fissures who are very difficult to treat for men having sex with men, and we're convinced that it can be an infection combined. So we treat, but there is no healing. Do you see them and are referred for surgery? MG infections, I also found. Sometimes does that delay healing? Well, hominis is a commensal one, is something we set aside. We have had, it takes so much time to find a MG for those fissures which do not heal. Well, if they are symptomatic, I would go for surgery, or I would go for histology first. In your practice, in your routine practice, if the patient with proctitis, do you also sample for the other bacteria? Well, I do it in second line. No, we have multiplex systems allowing us to do everything we can. But I think it should be for second line because it's true that is a pathogen, but gonococcus and chlamydia is more common, and the combination with proctitis is a higher percentage. And MG is quite often present, but it's in 10% of the cases it's non-symptomatic. If there's another germ which could be considered, in addition to chlamydia, it's simpler. It's more often found with a symptomatic proctitis. And if there is resistance to the treatment, then we will go for specific MG detection. And with a PCR, is the antibiogram performed? And there is no antibiogram for MG because there is no petri dish growth. It's done for gonococcus because you can grow it, but it's extremely difficult I don't think that worldwide there is no laboratory performing MG culture or growth. So it's molecular biology and mutation identification, which might be leading to prone resistance. In practice, if there is a chlamydia pro-ecdyditis plus MG, you will treat with doxycycline for 20 days, you could think that it would help you to eradicate genitalium. So it's a curative treatment. Well, doxycycline is also very efficient, but don't hope that much for MG. It's only 30 to 40% eradication rate. But it's true that it is still an efficient and effective treatment. So we may hope for an improvement. It will reduce the bacterial load, and it will probably help to heal the proctitis. No more questions? Well, thank you very much.